Thank you for joining me today. It's my absolute pleasure to provide this presentation on menopause and your heart. For those of you who have not met me or don't know me, my name is Dr. Emma O'Donnell. I'm an exercise physiologist here at Loughborough University, and my areas of research interest are very much centered on the cardiovascular effects of sex steroid hormones, specifically estrogen, and I'm interested in interactions between exercise training and sex hormones on cardiovascular health in women. So just to get off to a very simple start, let's look at the overview of what I'd like to go through today with you. I hope I'm not preaching to the converted entirely, but I just want to clarify what we mean when we talk about menopause. I want to talk a little bit about menopause, estrogen, and cardiovascular health. And of course, being an exercise physiologist, I would like to touch on a little bit about exercise and cardiovascular health. And I'd also like to go through, in brief, a little bit about hormone replacement therapy and what we understand about hormone replacement therapy and cardiovascular health. So first of all, let's be very, very clear. Menopause is not a disease. It's not an illness. It's not a medical condition. This is a natural part of a woman's life. But as some of you may be very aware, there are very quality of life related implications that pertain to the various symptoms of menopause. And I'll talk a little bit more about some of those shortly. But there are also very real health implications associated with these symptoms and with menopause directly. And those include osteoporosis or impairments in bone health, cognitive function, which my esteemed colleague, Broadhurst, will talk about next week, and obviously my area of specialty, cardiovascular disease. We have a very good, clear understanding that there is a very direct impact of menopause on heart health in women. So just to give a really broad, simplistic definition, when we're talking about menopause, we're talking about that time in a woman's life when her periods stop, not due to pregnancy or any other matters, they just stop completely, and the ovaries lose their reproductive function. Now, the average age for this to occur is between the ages of 45 and 55. And by around the age of 54, about 80% of women will have gone through menopause. In average, just to give you an indicator, the average age of menopause is 51 years of age. So to contextualize that in the UK, currently there are around 13 million women going through or have reached menopause. So that's around 1 in every 3 women. Now, amongst these 13 million women, there are around 1 in 4 who say that their menopause symptoms affect their quality of life. When we look at this list provides some of those symptoms. Some of them I'm sure that a few of you will be very familiar with in terms of the very common symptoms if you are symptomatic, such as hot flushes, night sweats, which are essentially hot flushes occurring during the night. If you're in that perimenopausal window, so a bit before that final menstrual period, you may be experiencing irregular periods. You may also be experiencing loss of libido, or sex drive, also vaginal dryness and mood swings. These are the most commonly reported symptoms. But you can see from this list, it's quite extensive in terms of symptoms as they relate to pains or changes or other symptoms that relate to menopause. And depending on the individual, you may experience any number of these symptoms in collaboration together. So I want to focus a little bit on the most prevalent symptom, and that is the hot flushes. They are recognized, so I've just got something on the top of my screen, I need to get that off. They are recognized as the most common menopausal symptom, affecting around 80% of symptomatic women. And when we talk about hot flashes, what do we mean? So these are probably best described by most women as that sort of intense feeling of searing heat appearing in the chest region, the neck and the face, increases in body temperature. Some women also describe increases in pressure in the head. And some women also describe rapid or irregular heartbeats or palpitations. In terms of duration of a menopausal hot flash, it could be anything between 30 seconds, but it may last as long as 5 minutes, with the average being reported around 5 minutes. In terms of frequency, this will be really varied. Some women only experience 3 to 5 hot flashes a day, while others report as many as 20 in a given day. And in addition to the frequency, there's also the severity of hot flashes. So some women will report that they just feel very mildly warmed or elevated in terms of their body temperature, while other women will describe a very intense searing experience, which induces profuse sweating. So how long could you expect to experience hot flashes if you are symptomatic? Well, depending on the various studies available, anything between 4 to 7 years is classified as average. But around 10% of women go on to continue to report hot flashes for around 10 to 14 years. So quite extensive for some individuals. Sorry, my slides are not advancing. There we go. I don't know what that was. So in terms of symptoms, you can imagine that if you're having sufficient experience of high frequency and high severity, particularly hot flushes, this can have a very real impact on work. And a 2017 white paper document from the Department of Education investigated what the impact of menopause is on work. And within this report, women are identified reporting a list of symptoms that are associated with, as a consequence of the menopausal symptoms that relate to work, so such as daytime tiredness, forgetfulness, reduced ability to focus, make decisions, impaired job satisfaction, decreased emotional resilience, inability to complete tasks efficiently, loss of self-confidence and self-esteem, and also increased experience of anxiety and depressive symptoms. Now, it's not surprising that if any of these or a collection of these symptoms applied to any given individual, that the same study reports approximately 5% of women say that they left work altogether due to the fact that they were not able to cope with their menopausal symptoms. So why are we experiencing these menstrual symptoms? It's a very good question. And I'm afraid I can't give you a definitive answer, but we do know that the steroid hormones in women, so estrogen and progesterone, particularly estrogen, does play an integral role. So we've talked quite a bit about the hot flushes. And this slide sort of talks about the effects of estrogen here. So let me orientate you to this slide. So we're talking about the effects of estrogen on the body. So beyond the effects of reproduction on the uterus and the ovary and the breasts, estrogen does exert numerous effects on the body. And if we start with the brain, we can see that estrogen has a modulatory effect on body temperature adjustment. We think this is part of the contributing effects of estrogen or estrogen deficiency in changes in the vasomotor symptoms that we see in postmenopausal women. We also know that estrogen influences memory function and also libido. At the level of the liver, we know that estrogen has favorable effects on cholesterol production and regulation. And we also know that estrogen plays a fundamental role in maintaining bone strength and density in women. Estrogen has anti-aging effects at the level of the skin, which is great. And also, as it pertains to today's talk a little bit further, we know that estrogen exerts favorable effects on the heart. I'd like to spend a little bit more time talking about that. So this very simplistic slide, this is certainly not an exhaustive slide demonstrating all the effects that estrogen has in terms of cardiovascular function and regulation, but it's simplified, and I hope it sort of makes a lot of sense to you in terms of, we know that estrogen, the 17-beta estradiol, so again, that dominant estrogen in premenopausal women, so this is women before they've gone through into menopause, 17-beta estradiol exerts favorable effects on blood pressure, in that we see lower blood pressure in premenopausal women compared to age-matched men. we know that estrogen exerts wonderful effects on cholesterol. It helps to increase the levels of the good cholesterol, so the high density lipoprotein, and it also helps to lower the bad cholesterol, the low density lipoprotein. Estrogen also helps to regulate metabolism and body weight. And estrogen also exerts favorable effects on the blood vessels, help keeping them nice and compliant and supple. And it also protects the heart in a number of ways. So collectively, these beneficial effects of estrogen are thought to contribute to the lower risk of heart disease that we see in premenopausal women compared with age-matched men. So just to explore that a little further, if we look at this chart, we're just looking at the percentage of deaths due to cardiovascular disease, men versus women. It's a pretty old slide, but the trajectories and the information presented really hasn't changed that much over the decades. So we're looking at the blue bars. These are the boys. If we just look at their trajectory, so we can see that with increasing age, as shown on the x-axis there, we see that increasing age, we see increasing risk of cardiovascular disease in men, which makes perfect sense, and we know this to be true. But if we look at the trajectory in women, it's a very different trajectory. And we can see that during what we call the premenopausal years or the reproductive years, certainly up until around the age of around 50, where menopause occurs, we can see that women present with much lower cardiovascular incidence of death compared to age-matched males. And then as women progress through the decades, they tend to catch up with men and then surpass men. So this accelerated trajectory, if you will, is said to sort of be onset or instigated by menopause itself in association with the effects of the loss of the cardioprotective effects of estrogen. Well, let's have a look at the estrogen levels here across the stages of menopause, because this will help contextualize as I move forward. So again, this chart is just a cartoon type schema thing. Here we've got estrogen levels and we have age along the x-axis. So that perimenopausal period there on the far left of the chart, we can see this decline in the levels of estrogen, which are quite marked. During this time frame, what we tend to have is women reporting less regular periods and estrogen levels gradually decline. Women then move into what we call this menopausal window. So 12 months after that very final menstrual period, the FMP, what we see is that women move from perimenopause into menopause, and after 12 months, they actually move into postmenopause. So more than 12 months after that very final menstrual period, women become postmenopausal. And what you can see from this chart is that throughout menopause and menopause, women become chronically estrogen deficient. So going back to that schema, we talked about the cardiovascular protective effects of estrogen. Let's now consider what are the cardiovascular effects of estrogen deficiency in women. So what we tend to see as we move into the postmenopausal period with increasing age, we start to see that there are increases in blood pressure such that women commonly develop hypertension with aging. We see increases in the bad cholesterol, so the LDL levels are going up and the good cholesterol levels are going down. That's the HDL. We also tend to see increases in body weight quite commonly. And collectively, the increases in body weight, the changes in the lipid profile, and the increases in blood pressure are associated with increased likelihood of developing the metabolic syndrome, which is also associated with an increased likelihood of developing type 2 diabetes. Estrogen deficiency also has an impact directly on the blood vessels. They become stiffer, essentially. And in addition, the heart also becomes a lot stiffer. And both of these factors help to contribute to the increases in blood pressure that we see. Collectively, these perturbations, these changes that occur in postmenopausal women are thought to contribute to the development and the progression of heart disease. Okay, it all sounds like doom and gloom, and I don't want to be here to cause panic. There are some definitive positives about getting to menopause, such as no more periods, no more cramps. Certainly, you can have no more pregnancy worries, which is a great thing for some of us. end of hormonally related headaches, if this was you, if you were experiencing hormonally related headaches, certainly through perimenopause, where it becomes quite commonly reported in women, they may start to abate and calm down or go away together. If you were unfortunate enough to have fibroids, going through menopause may help them shrink. But also menopause is a time for women to start to feel empowered, because this is really a time to start to think about you. Most women are at that time in their lives where they may be reaching a career high. They've got to that job that they've always wanted. Their children have fled the nest. It's sort of that time for you to be able to think about yourself. And good news, exercise can also help keep you healthy, and it may also help with the hot flushes, which would be great. I know we're all probably on the same page here, but we do know that exercise has lots of benefits for everybody. But in terms of menopause, it may be more important. We know that exercise improves muscular strength. We know that it improves bone health, so it helps to attenuate or slow down the loss of bone due to estrogen deficiency. Exercise also helps to maintain body weight in a healthy region that you want. Cardiorespiratory fitness is maintained or even increased with exercise training in postmenopausal women. And importantly, exercise also helps to keep blood pressure low in a favorable range. It also helps to modulate that lipid profile in a beneficial way. And collectively, not surprisingly, exercise lowers the risk of heart disease. So what about the effects of hot flashes or other symptoms? Can exercise help? Well, I guess the answer depends. There's evidence to support, and there's unequivocal evidence which would suggest there are no effects. But what I want to present to you today are some of the studies that do present some beneficial effects of exercise on hot flushes. So low to moderate exercise intensity has been shown by some to elicit beneficial effects. Well, with aerobic exercise, we're talking about walking briskly, jogging, cycling, 24 weeks of moderate intensity exercise, 30 minutes about 3 to 5 times a week, was associated with decreased risk of frequency and severity of hot flushes, and also increases in fitness, which is great. Yoga has also been demonstrated to help improve sleep disorders. So women that were really complaining of not getting good quality sleep, yoga was demonstrated to improve sleep quality and also to decrease hot flash frequency and severity. Resistance training, which is really paramount for maintaining muscular strength and also to help keep those bones healthy, has also been demonstrated to improve the frequency and severity of hot flushes. And nothing too rigorous, 8 to 12 repetitions in 2 sets 3 times a week, very simplistic, quite low level really, but proved to be quite beneficial over a 15-week period. Other benefits obviously associated with exercise can be noted, and some of these include improvement in quality of life as reported in these studies, fewer headaches, reduction in anxiety, and improved mood and self-esteem. So essentially, exercise can confer potentially some benefits in terms of your menopausal symptoms, your hot flashes, but may also contribute to a better quality of life. But there are some other considerations around hot flushes. As I said, we're not really sure essentially what's causing the hot flushes. We do sort of understand that it's likely to be a multifactorial causal process going on, but we know that estrogen does play an integral role. But other factors that are associated with increases in hot flushes and severity are smoking. Smoking is associated with increases. Obesity is associated with augmented hot flushes. Lower socioeconomic status. These women are more likely to report high frequency and severity of hot flushes. And ethnicity. So of interest, we see that in Black women of African descent, they are more likely to report increased frequency and severity of hot flushes compared to European descended women, who are going to more likely to report compared to Japanese and Chinese descent women, who are more likely to report increased frequency and severity of hot flushes. Iron women. So quite varied across the board. And you can see here how sort of multifactorial the cause of hot flushes may be in every, under any given circumstance. So what about the management of these symptoms? And this is a tricky business. There are purported non-pharmacological benefits. I've talked a little bit about the benefits of exercise, but again, as I've mentioned, it's some studies do support it, some studies don't. But in terms of efficacy, we know that hormone replacement therapy is very efficacious in resolving symptoms for women. However, I recognize completely this is not for everyone, and this can be a personal choice. You just don't want to take hormone replacement therapy, but there may be some clinical reasons as to why you cannot use hormone replacement therapy. What I'd like to do now, though, is go on a little bit and talk about what is hormone replacement therapy. So very briefly, so in the interest of time, I'm trying to keep it quite tight, but essentially hormone replacement therapy replaces the hormones that a woman's body no longer produces. So this is estrogen and this is progesterone, and these hormones mimic the effects of estrogen and progesterone in the body. So when we talk about estrogen in women, we're talking about estradiol, which is that dominant estrogen during the reproductive years. We also have estrone, which is the dominant estrogen in postmenopausal women. This estrogen is a much weaker estrogen than estradiol, so it doesn't confer quite the same beneficial effects that estradiol does in terms of cardiovascular health. And estriol also, and this is produced in abundance during pregnancy. In terms of a progesterone, this may be a synthetic version of the hormone, such as dydrogesterone, medroxyprogesterone, and I've only listed a few here. There's quite a long list, but medroxyprogesterone, we'll talk a little bit more about that one shortly, as it's used or has been used quite commonly in a number of clinical trials. But there's also what we call micronized progesterone that is chemically identical to the human hormone progesterone. Of importance to note that in women who still have a womb, so if you have not had your hysterectomy, you undergo hormone replacement therapy, you will be provided estrogen and progesterone combined. You will have to receive hormones. In women who have undergone hysterectomy, these women need only take estrogen only. Now, the progesterone in the women who have the intact uterus or still have their womb is administered to diminish the risk of endometrial cancer because progesterone helps the uterus slough off that lining and induce that withdrawal bleed, which is really important in women who still have a womb. And again, in brief, it's important to sort of comprehend in some respect that there are various what we call preparations. So oral tablets, we have transdermal preparations. So this would be a skin patch that would be applied to a part of the body and regularly replaced. It would just gently elute hormones over a given period of time. Gels are available, and these contain the hormone and can be applied directly to skin. There's also pessaries or creams that are applied directly to the vagina, and this may be for vaginal dryness or atrophy of the vagina. And there are also implants, so subcutaneous pellets. So that's a little pellet of hormone, if you will, put under the skin, and it just elutes hormones. But this is not typically implemented. You're more likely to receive any of the above types of preparations versus the implants. So having talked about the favorable effects of estrogen, which was derived primarily from experimental studies, from observational studies, we generally acknowledge that during the premenopausal years, women are cardioprotected. Endogenous, so the estrogen that's made within the body. So a number of observational studies have been conducted, large and small, and there's been a very consistent reporting in postmenopausal women who take hormone replacement therapy present with improvements or more favorable cardiovascular health compared to women who don't use hormone replacement therapy. And this sort of made sense in the context, if estrogen is cardioprotective, why not give it to postmenopausal women and perhaps delay the onset and the progress and the development of coronary artery disease? However, more robust and scientific studies were needed, so randomized clinical trials were needed to really investigate and confirm that hypothesis. And trials were launched to confirm whether hormone replacement therapy could indeed prevent or reduce cardiovascular disease in postmenopausal women. One of the earlier clinical trials, and I'm certainly not going to go through all of them, but I'm just going to iterate a couple of the landmark studies because it provides context as to what happened to hormone replacement therapy back in the early 90s, or the early noughties, as it were. So the HERS study, conducted in 98, was a randomized clinical trial in postmenopausal women who had established coronary artery disease. So they already have heart disease. The research question for this particular clinical trial was, can hormone replacement therapy, can it prevent or can it lower the risk for a second heart attack in postmenopausal women who already present with heart disease? So this type of investigation was classified as a secondary prevention trial. So we're not trying to prevent the development of heart disease in the first place, which would be considered a primary prevention trial. This is a secondary prevention trial. Looking at just some of the details that relate to this study. So there were around 3,000 women, just over or just below, divided equally into a hormone replacement therapy group or a placebo group. The mean age of these women were around 67 plus or minus 7 years, with the range around 44 to 79 years of age. So again, just to remind you, these participants were postmenopausal women with established heart disease. The hormone therapy used for this particular study was comprised of what we call conjugated ekine estrogen, CEE. This was very much the standard estrogen format used at that time. Conjugated ekine estrogen, as the name suggests, does contain a number of estrogens, some of which are found in the human body, such as 17-beta estradiol, but predominantly those that are found in pregnant mares. So there's about 9 to 10 different estrogens within a conjugated ekine estrogen preparation. And it's just important to contextualize that for you, just so you understand we're not just talking about giving a woman 17-beta estradiol back. We're talking about just giving her estrogens, a variety, a collective of different estrogens. And in concert with the CEE was the medroxyprogesterone acetate. So that was the progestin, or the progesterone, the synthetic progesterone of choice. And this dose that was used and this preparation, this route of administration was very much standard practice at that time. This study had a follow-up duration of around 4 years. And what this study reported was that HRT may increase the risk of a blood clot and heart attack during the first year of therapy. However, this risk was decreased after a year. And the researchers decided with this, in terms of interpreting the study findings, was that, well, HRT does not confer any benefit to cardiovascular disease risk, so therefore should not be prescribed for the prevention or should not be prescribed for secondary coronary artery disease prevention. The next study to follow was the Women's Health Initiative. This was a very large randomized clinical trial in healthy women. And what they wanted to ask was, can HRT prevent the development of heart disease and heart attack in postmenopausal women who are healthy? So this is a primary prevention trial. We're trying to prevent the development of heart disease in the first place. So looking at the two groups here, so the much larger study group size, so approximately 16,000 women divided into two groups, a hormone replacement group and a placebo group. And the mean age was around 63 plus or minus 7, so ranging from around 50 to 79 years. And the age of these women will become important in a moment, but I'll iterate that shortly. I'll go back to that shortly. So again, to remind you, these are healthy postmenopausal women with no known coronary artery disease. They also took the same hormonal regimen as in the previous study, because again, standard preparations and doses at that time. The planned duration of this study was 8.5 years, but the actual duration was 5.2 years. And that reason being it was cut short is because the study was halted. because the investigators identified or reported that HRT increased risk of heart disease, blood clot, stroke, and increased risk of developing breast cancer. So what were the consequences of these trials? Well, essentially, it was the death knell for hormone replacement therapy. So HRT was all but ceased being prescribed to postmenopausal women, even to highly symptomatic women. And longer term, it also decreased the education training for doctors around the topics of menopause and hormone replacement therapy. Questions that arose because, as a consequence of the findings of these studies, were why were the findings so inconsistent with the previous observational studies? Why didn't hormone replacement therapy prevent cardiovascular disease risk? And why did HRT increase the risk of certain cancers, specifically breast cancer? Well, some of the potential shortcomings, is probably not the right word to use, but there were criticisms of both of these studies, one of which was the choice of HRT. As we discussed here, the oral preparation of CEE and MPA were used. Could other preparations or doses be important? And in the interest of time right now, in the context of blood clots, definitely yes. We see with oral preparations, we see greater increases or higher prevalence of blood clots compared to other preparations. And other considerations were, what about the age and the timing of initiation of hormone replacement therapy? Remember, in the HERS study, the women were on average 67, and in the Women's Health Initiative, they're around 63. So these women are considerably past their final menstrual period. And this may help to explain, or at least it was thought to help perhaps explain, why we're not seeing consistency across the board compared with the observational studies where the women were considerably younger, where they were being prescribed HRT for symptom management. So that essentially they're much, much younger. So the question was, well, perhaps age is important and the timing of the initiation of the HRT is important. So the Women's Health Initiative went back and did a little bit of sub-analyses of their younger women. About a third of their cohort were between the ages of 50 and 59. And they reported that in this particular group, there was no increased risk of heart attack or coronary artery disease. And in fact, in this group, we saw lower all-cause mortality compared to the placebo group. And this group reported that cardiovascular risks of HRT are very low in women who are less than 10 years from menopause and are under the age of 60, compared with the older women who are further from menopause. So these findings led researchers to propose a timing hypothesis. And without going into too much detail on this slide, because it's quite busy, but essentially, the slide is showing here in the red box is a healthy artery. And what we were thinking at this time is that HRT given to young postmenopausal women, their vessels are healthy, and HRT would have favorable effects in a healthy artery, compared to older women who are more likely to be presenting with some degree of arterial disease, whether it's coronary artery disease or hardening of the vessels. We were thinking that perhaps HRT has an adverse effect in diseased arteries. And indeed, several subsequent studies have been designed to test both the timing hypothesis and also to look at preparation significance in terms of if it mattered if we were giving transdermal versus oral in terms of coronary artery and cardiovascular disease risk, and identified that essentially the timing hypothesis was accurate. So today, certainly from 2019 at least anyway, it was recognised by the British Menopause Society, the National Health Service and the National Institute for Health and Care Excellence, that HRT and HRT prescribed before the age of 60 or within 10 years of menopause has favorable benefit risk profile and is likely to be associated with a reduction in coronary heart disease and cardiovascular mortality. And they also recognize that other lifestyle factors will help and contribute to this favorable effects, including obviously stopping smoking, reducing obesity, improving diet and undertaking regular exercise, all of which can help lower cardiovascular disease risk in postmenopausal women. So what about the elephant in the room? Let's have a little word about breast cancer risk, because this is certainly something that has been focused on quite significantly, certainly in the media. but it's an important and it's a controversial topic. The British Menopause Society put out a statement saying, well, it's important to recognise that most women will not be diagnosed with breast cancer in their lifetime. And it's also important to recognise ageing per se is associated with increased risk for breast cancer. And it's also quite intricately difficult to identify in the context of other lifestyles that there'll be other factors that could be contributing to the development of breast cancer, such as obesity, alcohol, and smoking. So what I wanted to do was to sort of just take you through a slide that hopefully contextualizes in some way the risk of breast cancer with hormone replacement therapy. If we look at the top of the slide, there's with the general population. So if we had 1,000 women aged 50 to 59, their risk of developing breast cancer in the next 5 years, we would anticipate to see that there would be 23 cases of breast cancer diagnosed within this cohort. If we look at HRT users, we would anticipate to see 4 more cases above what we would see in the general population not using HRT. In the context, just to sort of contextualize that again, in women who use oral contraceptives, so premenopausal women, the risk is reported to be the same. So the risk of breast cancer is equally, high is not the right word, but the numbers are very, very similar in terms of the risk for oral contraceptive users in premenopausal women versus hormone replacement therapy in postmenopausal women. So with alcohol, we would expect to see additionally maybe 5 more cases over above that seen in the general population in women who drink 2 or more units of alcohol a day. And smoking is associated with 3 more cases of breast cancer risk. By far and away, the biggest risk for breast cancer is obesity, where we'd expect to see a doubling, essentially, of the incidence of breast cancer among a cohort of this size, of this age group, in a 5-year category risk factor model. So obesity would be associated with 24 more cases over and above that seen in the general population. But also there's some good news. There are some factors that are associated with decreased breast cancer risk. So we have exercise. So studies indicate that we might anticipate to see 7 fewer cases of breast cancer in women who participate in moderate exercise for around 2.5 hours a week. And in studies that have looked at women who have had a hysterectomy and have been given estrogen therapy only, they report 4 less incidences of breast cancer compared to the general population. So all in all, I hope this sort of just provides us a little bit more context for you. So just to wrap things up, menopause is associated with many symptoms, but predominantly hot flushes. And menopause is also associated with increased risk for cardiovascular disease. HRT is indicated for symptomatic women. It is not indicated for chronic disease prevention, such as coronary artery disease or cardiovascular disease. We do know that HRT is effective in alleviating symptoms, particularly hot flushes. And initiation of hormone replacement therapy in healthy women close to the age of menopause may also be cardioprotective. Lifestyle choices may also help with menopause symptoms and lower your risk for cardiovascular disease. We talked a little bit about those: so regular exercise, smoking cessation, and lowering or minimizing alcohol consumption. And final thoughts here, if you are somebody who's menopausal and is suffering greatly with your symptoms and you're finding it very difficult to cope, do talk to your GP about your options. Remember that exercise may be helpful, certainly from a quality of life perspective. It may help with your hot flushes if that's what you're complaining of. And obviously exercise benefits. And I urge all of you to get the most out of your menopausal years. Thank you.
Thanks, Emma. That was great. Really interesting talk. Thank you. Just while everybody's trying to find the reactions button to ask your question, I have had a question come in via email that I don't know if you'd be happy to answer.
Yes.
And it's, why does hormone replacement therapy help to stop heart palpitations? And secondly, is there a benefit to using HRT for those who've had radiotherapy, and in this case on the left side of their chest?
Gosh, that's okay. Let's answer the palpitation bit first. So it's not uncommon for women in perimenopause and going through menopause and becoming postmenopausal to report palpitations. It's actually quite common. I think it's important to reiterate, we're not talking about arrhythmogenic issues such as atrial fibrillation. We're talking about the occasional sort of that strong there's a skipped beat and then there's a boom, that kind of palpitation experience. That's very, very common. Hormone replacement therapy may help with that. There is some evidence to support that it does. We think that the palpitations come about in response to the estrogen deficiency, because estrogen plays an integral role in the modulation of heart rate and cardiac tissue itself. So we don't exactly understand what's going on there specifically, but we do know that there is an integral role again for estrogen in heart rate modulation. And so and hormone replacement therapy has been shown to be efficacious in modulating palpitations. In terms of radiotherapy, this is something I can't speak to knowledgeably, I'm afraid. And as to hormone replacement therapy in patients who've gone through radiotherapy, that would be something that you would have to discuss with your clinician. I'm afraid I'm not knowledgeable enough to answer that one.
Cool, thank you. Okay, we have got a hand up here from, is it Zena Needham, if you'd like to ask your question.
Sorry, can you hear me?
Yes, I can.
Yep.
Sorry, I just wondered about the whole lower sex drive thing. I'm wondering, is the estrogen enough for that? Because I've heard that there's one of the hormones isn't on offer for us ladies. You have to go private or something. Is that right? I don't know.
So if you are experiencing low libido, and this is something that concerns you, have a conversation with your doctor about this. I mean, hormone replacement therapy would be indicated for something like that. You may have read in and around the media that perhaps testosterone is the hormone of choice, because testosterone is certainly associated with libido in males. I think there are some studies that have looked at administration of testosterone specifically for low libido. But I'm afraid, in terms of, again, my level of expertise in and around libido, I can't talk too knowledgeably about which would be better, HRT or testosterone replacement or therapy. You'd have to have a conversation with probably somebody in a menopause clinic, or someone who's got a specialty in that area, so they would be sure to direct you accordingly.
Yeah, that is where I heard somebody did go to one of these plans and said, that's what they needed, and it isn't on offer on the NHS, and you have to pay private. But I just wondered if you'd heard any different. That was all.
Yeah, certainly. I don't think testosterone is prescribed for low libido specifically on the NHS, but I couldn't confirm that wholeheartedly. You'd probably need to go and ask your doctor if that is indeed the case. If that's something that you were looking to acquire.
Okay, thank you so much. Thank you.
You're welcome.
Cool. I can't see any hands up at the moment. There are a couple of questions in the chat, Emma, that I could read out if we can go through those. So one of the questions, I note the comparison between HRT and the placebo group. Can you advise what natural remedies have been studied versus HRT? Are you promoting HRT as being better than natural remedies? And would eating foods that support menopause symptoms not be better or just as good?
Good question, very good question. There are a number of non-pharmacological products available. So sage, black cohosh, phytoestrogens, isoflavones, so they're plant-based estrogens. And for some women, they are reported to be quite efficacious and helpful. And I think if that's you, that's great. Studies reported in terms of their efficacy and the level of evidence that's provided around these types of products are quite low, unfortunately. And the studies are not supporting a consistent beneficial effect. So I think it's very much a try and test for yourself. If you don't want to take HRT, that's your choice. And if there are other ways that help you manage your symptoms, great. to answer the question, HRT is the most efficacious therapy for your symptoms. So it's something that it's a personal choice at the end of the day. You can weigh that up, but that's what the evidence indicates.
Cool, thank you. Sarah's got a hand up next.
Hi, this has been really useful, thank you. I've got a question. I've been taking HRT for 18 months, and after a year I noticed that some of the symptoms started to creep back in. So my GP suggested that I increase my estrogen because I was taking a very slow amount. Can that increase cause further hormone imbalances? And in my case, I wasn't having periods. I was having like 1 a year, 2 a year. And since I've started taking a higher dose of estrogen, I've had 2 periods in 2 months. Is that normal?
I mean, in terms of hormone replacement therapy, I think in terms of how your body responds, that may be slightly different to how other women may respond. But I think your initial question there around potentially increasing your estrogen dose on recommendation from your doctor to help better manage your symptoms. Typically, when you go to the doctor and you complain about your hormonal symptoms, they will start you on the very lowest dose possible to see if that's sufficient. And it will be for a lot of women, but not for all. And you may need to increase it. So are you taking oral or is it transdermal?
I'm taking the gel for the and then I'm taking progesterone continuously. So my doctor's worried me because she said I shouldn't be having periods at all on HRT. So I'm now in the system of going for scans, and they found that my lining of my womb was a little bit thick, but then I had a period a week later, so that's why the lining of the womb was thick. So I'm trying not to worry about it, but it's and then it brings on anxiety knowing about, you know, this kind of change in my cycle again. Yeah.
Did you have issues in your menstrual cycle when you were menstruating? Did you have particularly heavy bleeds? Were they irregular or anything like that?
Yeah, I mean, I had PCOS, and they were I had a very short cycle and sometimes a very long cycle. So I'm completely you know, I've no idea where I'm heading, to be honest. Whenever you go for scans, they ask if you're perimenopausal or postmenopausal, and I have to say each time, I don't know.
It's difficult because you're on the hormone therapy there, and it's inducing a bleed. And also I think underlying what might be for you is that you have an underlying endocrine difference. You've got PCOS, so we know that will have a very marked impact on the menstrual cycle and your hormonal profile overall. So it's likely the combination of PCOS and getting that balance right between those HRT hormones for you. But I think as long as you're under the guidance of a doctor, and please express any of your concerns with them, you know, don't stay home and be anxious about this. Have a conversation with your doctor about it and share your concerns, because that's important. And you want to make sure that you're getting the best possible care. Like, is this the right thing for me? Should I be doing this? Or I don't understand why I'm getting these bleeds. Should I be getting them? If you're going in for investigation, that's good, I think. You know, let's rule that out. But I mean, as long as you're under care, and it sounds like you are, I think you're in good hands.
Thank you.
Thank you, Sarah. Kate, have you got a question?
Yes, I have. Thank you. Can you hear me okay, Emma?
Yes, I can, Kate.
Thank you. That was a really, really useful talk. I was interested particularly in the stuff around the sort of cardioprotective nature of HRT, and I wondered if there was any. I've got a history of cardiovascular disease in my family, in my mum, and I wondered if that would affect my decision. I'm thinking about going on HRT, whether it would encourage it or discourage it.
Well, evidence suggests that even women who might potentially be contraindicated in terms of having present cardiovascular disease risk, i.e. maybe some level of coronary artery disease or hypertension, are not precluded from HRT, but obviously discussions around the appropriate type of HRT need to be had. But remembering that HRT would only be indicated for the management of your menopausal symptoms. It would never be indicated for, okay, let's give you HRT to help prevent the development of cardiovascular disease. They just wouldn't do it. I mean, when you go to see your doctor, and they're going to assess you. and they're going to determine your appropriateness for HRT. So they, provided you've got somebody who knows what they're doing, and it's not to be disparaging of all doctors, but some doctors are better trained than others. You should be able to have a very open conversation about your concerns about that. And if he's picking HRT, why is he picking this one? Just so you know, and put your mind at rest.
Yeah. Okay. Thank you. That's really helpful.
Thanks, Kate. Lisa.
Yeah, hi. I just wanted to ask a question on exercise and obviously the benefits that has in general for your heart. I bought a menopause magazine, which was really useful. On one page, it was talking about HIIT, so high intensity, interval training, and was saying that's very good. And then a few pages later, it was saying you should really avoid that and probably stick to something like running or walking. So I just wanted to get your input in terms of what you think is good exercising to be doing for someone in that position. And I am on HRT as well.
Okay, so I guess the question is, have you always been physically active, or is this something you're thinking of taking up as a new thing?
So I've more recently started doing it because I've noticed very much the middle age, the waist has suddenly gone. I'm slightly overweight. I'm definitely not in the higher BMI, but I'm probably around the 28 BMI. So I just thought I don't want to stick to one exercise. I'd like to probably try and mix things up. So I've been doing some HIIT, but then I was just worried, actually, am I doing more harm than good?
Well, HIIT, high intensity interval training, just as the name suggests, is very high intensity. So it's very exerting. You'll be out of breath, huffing and puffing, and typically you do repeated bouts of it. So you'll do high intensity for 30 seconds, and then you'll sort of do low intensity for 30, high for another high, another low, etc., etc. And you do at least 6 repeats. So I'm not sure what the magazine was describing HIITs were. Quite often HIITs are used, they're used across the board to increase cardiorespiratory fitness, and they're very good at burning lots of energy. So I could see why they put it in the magazine, but it's interesting that in the same magazine, they're saying avoid them. So it was that avoidance to a specific group of women that they were concerned about. If you were very...
it was just a bit, the magazine was actually just a bit confusing. I'm not advanced on HIIT. I'd probably say I'm more sort of, basic to intermediate. So you can determine the level of exercise that you do, but it's... Yeah.
Or, typically you could perform a HIIT. Doesn't have to be ultra high intensity. It could just be higher than usual. You would still reap good cardiorespiratory gains from that, and you'd still burn lots of energy. You could perhaps monitor that, gauge that for yourself. But if in doubt, it may be worth speaking. Are you a member of a gym or anything like that?
No, I'm in the country, so don't have access to a gym. It's
it'd be nice
through apps. Yeah.
Right. It would be good to have some guidance, I think, a personal one-on-one session to explain this to you, what would be best for you. But beyond HIITs, everything else that you're doing, if you're doing moderate intensity aerobic type exercise, try to incorporate some resistance training if you can as well, because that's great for the bones. You're doing the right things. But with the HIITs, I wouldn't deter you from it necessarily, but it would be nice to meet with you and evaluate you to make sure that you're all good for that to go. But we use HIITs in cardiac rehab, if you can believe it. They're perfectly capable of doing them. So, there's no reason why you can't do them. But if you're concerned about it, I would have a conversation with somebody who, a physical trainer somewhere in your area, because there'll be somebody in your area.
Okay, lovely. Thank you.
You're welcome.
Thanks, Lisa. Emma, we've got 4 more questions left that hopefully we can fit in before past. What I was going to suggest, if it's okay with you, is if I leave the chat open at the end of this call, if people have any further questions, maybe they can put them in the chat and we will try and answer them at a later date if we can.
Yeah, no problem at all.
Happy with that? Yeah. Cool. If that's okay, then we'll move to Elaine. I think, Elaine, did you have a question?
Hello, can you hear me?
Yes.
Yeah, we can.
Lovely, thanks. Just trying to find the mute. I've actually got 2, but hopefully it's a bit not too long. So my first question was really about endometriosis. I've got severe endometriosis, so I was really delighted when my period stopped. But then, due to symptoms, I did go and see my GP and tried HRT. I came off it again because it started really heavy periods again, as well as really painful breasts, and I just felt that was even worse, so I just came off it. But I wasn't sure really whether to sort of go and try and have another go and try and because I'm quite attracted by that sort of protective benefits that you get for the cardiovascular side of things. So that was really one question. And then the second one was, if you do start on HRT, how long would you expect to be on it for?
Okay, two good questions. I'll try and be brief. So with the endometriosis and the HRT, I'm not sure what type of HRT they put you on. Was it transdermal?
Yes.
It was, because typically it is like 50 micrograms of estradiol, so it's probably the low end dose anyway. Do you remember?
You're probably right. I don't know, I'm afraid. I just know there were the patches.
Yeah, you may find it challenging to try to take HRT to manage any symptoms that you have because of your endometriosis. I'm not saying don't have a conversation with your doctor about that, and maybe see if there's something else that could be tried, whether it's a gel or something along those lines. But it may just be a challenge because of the fact that estrogens are going to, and the progestins are going to have conversations with your uterus and your endometriosis, and it's not going to be pleasant. So you might just find it challenging, full stop. Your final, sorry, I forgot your second question now. Sorry,
it's how long you would stay on HRT normally.
So that really depends on the individual, but typically, again, physicians like to administer the lowest dose possible and like you to use it for the shortest time possible. Makes sense. If it's managing your symptoms, great. If you don't need it anymore, come off it. Ideally, less than 5 years, because the evidence would suggest that certainly from a cardiovascular disease risk and risk of breast cancer and things like that, it would seem that 5 years or less doesn't increase the risks. So it's perfectly safe to take. So I would sort of think I'd be along those lines if we're worried about breast cancer risk and perhaps increasing our risk of heart disease. 5 years or less.
Lovely. Thanks very much.
Cool. Thank you. We'll try and fit in the two last ones. Rachel.
Hi, thanks very much. Really interesting presentation, thank you. And it follows on really from the last question. So I had a full hysterectomy at the age of 35 and I'm now 50. And I've been on estrogel for that whole 15 years at as low a dose as I could possibly maintain at. I noticed they have tried to bring me off it on a couple of occasions just to check for symptoms, and I have horrendous menopausal symptoms really quickly. I'm mid-studying, and I'm thinking my GPs are perhaps going to suggest that I come off it at 52, and I'd rather like to carry on a little bit longer. So what's the kind of suggestion around that, or the research around when you've been on it for a long period of time? Is it again coming off it as soon as possible?
It's different for women with hysterectomy. Certainly somebody at the age of 35, we know that once you take out the womb, potentially also the ovaries, estrogen levels are impacted, and you need to replace estrogen because of the impact it will have on heart disease risk and on your bone health. So typically I think practice is that you are taken off the hormone replacement therapy around the time of what would be otherwise normal natural menopause, around 51, 52. So you're probably right. They might be looking to try to get you off. But have a conversation with your doctor about your concerns, and maybe you need to be titrated off to help with those symptoms a little bit. But do have a conversation and express your concerns, and I'm sure they will be able to sort of understand, obviously you've got a very stressful time right now. You could just do without having those symptoms raging at this time. So definitely have a chat with them and share your concerns about the duration of treatment. Should you be concerned about that? Have those conversations, because I think really, that's important for your peace of mind.
Okay, thank you very much for that. Thank you.
You're welcome.
Thanks, Rachel. And one final question, if that's okay, from Daniela.
Hello, everyone. First of all, thank you for your great presentation. Before I ask my question, just very briefly, probably will be beneficial for everybody. I've been through menopause probably in the last 2 years. Maybe I'm postmenopausal now. I'm a physiotherapist by profession, but I've never had high intensity exercises in my life. I always liked the moderate. I was struggling with the hot flashes, and I have to admit that since I have joined my gym 2 years ago, I'm attending 5 classes a week, step and tone, body conditioning and spinning classes. Thanks to those classes, I got rid of my flashes. So I have no more flashes, and I really enjoy my postmenopausal period. My question is, because I had the bleed a year ago, and I have seen a professional, so I've been diagnosed with vaginal atrophy, and I've been given estrogen cream to use for a month. I stopped using the cream, and then I saw a private gynecologist. She suggested to keep using the cream as a maintenance twice a week. So I really don't know which is the right way going forward. I don't have any more symptoms. Do I need to carry on using the cream, or just to keep it in case I have any symptoms?
Very good. Well, I'm delighted to hear that the exercise has been beneficial. A success story for you. Great. In terms of the management of your symptoms of vaginal atrophy, so localized application with a gel or with a pessary or a cream is really, really helpful for vaginal atrophy. And it doesn't have the application, that route of administration does not have the same impact on your cardiovascular health or anything else. It's very, very localized. It's just for that local tissue. So your risks for breast cancer, for heart, anything like that are absolutely minimal. So
Okay.
for you, if it's helping, carry on.
Yeah. No, because I don't have any more symptoms now. I don't have that, I had some bleeds before, and also I had that burning sensation and just that rash. I don't have any of those symptoms anymore. Do I still need to keep as a maintenance dose twice a week? Or
I think, yeah, if this is what's been advised by your physician, I would go.
Yeah.
I would continue with it.
Continue.
Yes, definitely. It would be for a good reason. They wouldn't put you on it if they didn't think there was an appropriate reason.
Okay. I mean, the thing is that the private consultant suggested that, but then I have seen NHS doctor, actually the lady who did the actual examination, and, they did further tests. She said, just use it for a month, on the reduced regime, and then only if you have further bleeds. But because I didn't have any more complaints, so that's why I thought probably it's better to stop it. So that's my dilemma. One professional says yes, the other just maintenance. So that was my question. What do you think?
That's a very difficult one, because number one, I'm not a physician, so let's clarify that. So I wouldn't ever prescribe or tell anybody to take HRT. This is a very personal choice, and I think, unfortunately, you've received conflicting advice, which is not helpful at all.
Yeah.
And I don't know. I mean, part of me is thinking, like, do you go and get a third opinion on that?
Oh, right.
And just say, okay, can you please advise me on this? And again, try and seek out somebody who is a menopause specialist.
Okay, thank you very much.
And they are out there. Yeah.
Thank you.
You're welcome.
Cool. We better draw it to a close there. Apologies, we have overrun a little bit, but there were some great questions there. So thank you, Emma.
Thank you
again for a great talk, and thank you everybody for attending today. A bit of a plug, as Emma said, we have got 2 more of these sessions next week and the week after. Next week is Menopause and the Brain, and the week after, on the 22nd of June, is a live course approach to menopause. Both of these you can register for through our website as per this session. So thanks everybody again. As I mentioned, I'll leave the chat open for a little while, so if you want to put any further questions in, we will try and get to them after the event. So thank you everybody again. Enjoy the rest of your afternoon.